Hello, everyone. Today we have a little bit tricky case, uh, and the answer will mainly depend on your understanding of the renal pathology. She is a 33-year-old woman who came in to your clinic because of foamy urine and some leg edema. Physical examination revealed a blood pressure of 142 over 82. Heart rate is 80 and 3 plus pedal edema. Apart from that, her physical examination was benign. This is her most recent laboratory results. Serum creatinine 0.8, GFR above 60, hypoalbuminemia, serum albumin 2.7 grams, normal C3, C4, normal serology was negative. She has 8.6 grams of protein in her urine, and also she has some RBCs 5 to 10 on top of the 3 plus protein. This is her silver stain light microscopic picture. Her immunofluorescence was positive for IgG, IgA, IgM, C3, and C1q with some mesangial deposits and also reticular aggregates. This is her electron microscopy. And the question is, which one of the following tests is most likely to yield a positive results in this patient? Which test are you going to order and it will have um, good positive predictive value? ANCA testing, serum free light chain, ASO, ANA, or serum cryo? And the right answer is anti-nuclear antibody. And I'll show you in a second why it's essential and pivotal to rule out or rule in lupus nephritis in this case. So this lady have possibly membranous nephropathy, who is nephrotic syndrome. She came in with nephrotic presentation, foamy urine, like edema, 8.6 gram of protein, hypoalbuminemia. When we see the silver stain, there was typical spikes and holes in the glomerular basement membrane. You can see the spikes here are very prominent, and there is thickening of the basement membrane. On top of that, this patient also, her immunofluorescence had what we call full house. So stained positive for IgG, IgA, IgM, C3, C1q. On top of that, she has mesangial deposits and reticular aggregates, which are both suggest lupus nephritis, which is class 5 lupus nephritis with membranous nephropathy. Moreover, her EM didn't only show subepithelial deposit. Here is the intramembranous and subepithelial deposits, but also in the mesangium, you can see a lot of deposits in the mesangium. So it's not only in the basement membrane, the deposits, but also in the mesangium, and that's very typical for secondary membranous nephropathy, especially lupus nephritis, the class 5 with membranous nephropathy. So in these cases, we need to rule out secondary causes like infection, most likely hepatitis B more than C. Hepatitis C, as you know, can induce more MPGN, but hepatitis B is classically associated with membranous nephropathy. The second most common cause of secondary membranous nephropathy is autoimmune disease, especially lupus nephritis, then drug-induced like NSAIDs, penicillamine, and gold, malignancy, of course, especially solid tumor and lymphomas. So this woman is in her childbearing period, and as I showed you, she had negative serology for both hepatitis B and C, and she had a classic lupus nephritis. Despite that, she doesn't have extrarenal manifestation, but it's not necessarily. Some lupus patients, they have, you know, particularly lupus nephritis renal manifestation without systemic manifestation. But the vast majority, they start by having systemic manifestation with arthralgia, joint problems, you know, fever, hair loss, skin manifestation. Then they end up by having renal disease. But this doesn't have in 100% of cases. Some cases can present initially with lupus nephritis rather than with systemic manifestation. So ANA anti-double strand is very important in this case. Please don't order ANCA for this case. She doesn't have RPGN, rapidly progressive glomerulonephritis, or cholestatic glomerulonephritis. She doesn't have any pulmonary or systemic manifestation, upper or lower airway affection. So don't order unnecessarily ANCA or anti-GBM because false positive results happen. ASO is not necessarily, and also cryo because the complement is normal, and both of these disorders are usually associated with hypocomplementemia. Also, serum-free light chain is associated, as you know, with light chain deposition disease, which is usually characterized by nodular glomerulosclerosis, not by membranous nephropathy. So it's in the differential diagnosis of diabetic nodular glomerulosclerosis, not on this case. And here are the references for this case. I really appreciate having your time and learning today this challenging case of membranous nephropathy. Thank you so much and have a good rest of your day.